We're grateful for this event to the sponsors, Pfizer, Spectrum Cannabis, AbbVie, Novartis, BMS, Celgene, Eli Lilly, Massage Addict, Merck, UCB, and our regional sponsor, Spring Loaded Technology, for their generous support. Now, enough from me. Let's begin with our first arthritis expert. Cheryl is a co-director of the Dynamics of Human Motion Laboratory and professor in the School of Biomedical Engineering and School of Health and Human Performance at Dalhousie University. Quite the title on her business card. Her research focuses on knee joint osteoarthritis and supporting mobility. Please welcome Dr. Cheryl Kozey.
Where's the button? Okay, thank you very much, Joan. It's great to be here this afternoon to chat with you, and the previous speaker was a great segue into what I'm going to talk about here. So the topic is mobility for life, and I'm extremely passionate about this topic because we know that we need healthy joints, bones, and muscles to be able to maintain mobility and function. And if we think about our overall health, our mental, physical, and brain health are very important, but they are compromised if we aren't able to move. And bone and joint disorders are the key area where which cause problems or deficits in movement, in particular bone and joint problems like arthritis of the lower limb. So over 6 million Canadians, I think you probably maybe heard this today, have some form of arthritis, and osteoarthritis is the most common form. Nova Scotia, we have about 23 or 24% of our population, but it's not just a local or a Canadian problem, it's a global problem. And there are over 250 million people globally who have osteoarthritis. So the burden on many individuals trying to live with osteoarthritis, as well as the healthcare system, as well as an economic burden, because it's not just older people who have osteoarthritis or other forms of arthritis, younger people do as well. So it does impact their ability to work and do other types of activities. So my focus, as Joni said, has been on osteoarthritis. And osteoarthritis is the most common form of arthritis, and it's the most prevalent chronic condition that decreases physical function in older adults. But it is not a normal aging process. It is a disease. It's a disease where you have an imbalance between the cartilage being generated and the cartilage breaking down. So there's a disruption in that. So it isn't a normal part of aging, which some people think that it is. Now, the articular cartilage, so that's the cartilage that surrounds the bones at your joint, is a nice lubricating structure. And when that starts to break down, that's when we start to say that we are having, that's part of a diagnosis for osteoarthritis. But what we do realize is that it's not just the articular cartilage, it's actually the muscles, the nerves, the ligaments, all of the joint structures become impaired, or they have a deficit associated with them. So when we look at that, there's a disease component with respect to the damage that takes place in the joint, but there's also a component with respect to all of these other tissues, and they can relate to what symptoms you have. So as far as your pain is concerned, as far as your stiffness, all of those types of things, muscle weakness, and they all contribute to this illness component. And to have osteoarthritis diagnosis, you have to have both of those things present. Because most people in the room who are over 40 years old will have some changes to their joint, but some people, mostly people in this room, would have some form of arthritis. But in the general public, they might not have pains and symptoms, even though they do have some changes to the joint. So the current clinical pathway with respect to osteoarthritis is you have a diagnosis based on this damage as well as your symptoms, and they're primarily stiffness, pain, and those types of things. But primarily we look at pain medication as our management approach. And oftentimes what happens is we just wait around until it might get so bad that you do have to go on to a joint replacement. And what I'm suggesting in some of the work that we're doing is that we're really trying to say there must be another way that we can deal with this to keep people functional and doing the things that they want to do. So looking at how we can change that pathway up, and things like the GLAD program and integrating those types of things is extremely important, but how do we actually get those into our model of care? So what we look at is this framework from the World Health Organization that's called the International Classification of Function. And basically what we look at is on the left-hand side here, if you have an impairment to the body, so in osteoarthritis you have an impairment to the joint and the joint structures, that limits how you move, and it changes how you move. And how you move can in turn determine what types of activities you can take part in. Now, there's other factors that come into play as well, like environmental factors. So what type of work do you do? Is it a very sedentary type of job, or is it something that requires a lot of kneeling? So those factors can come into play, as well as personal factors, so some genetic factors, or maybe your weight, and those types of things can also come into play to affect the disease process. But the key thing is we want to look at how that impairment actually affects what we can do, limit what we can do and what we can participate in. So we know from a recent study that mobility is a key with maintaining health of individuals with osteoarthritis. And we know that individuals who have mobility deficits have higher numbers of coexisting conditions, such as brain health issues, such as cardiovascular issues, so heart issues, diabetes, obesity, all of those types of things, because the mobility, if you can't move, then you can't take part in activities that are beneficial for you to maintain general health. If we look at osteoarthritis, and we look at how that compares to other joints, if we look at other diseases, this measure on here is called the Frailty Index, and it gives us a measure of overall health status. And if we think that osteoarthritis is not a problem, if we look at age along this side here, this would be an individual this would be a population study of individuals, and this would be their frailty index, with a low index being a very fit person and a high index being a very frail individual. And what we see is that osteoarthritis here, this blue line, is much higher. So you are less healthy because of these conditions than an individual that doesn't have that disease. But also we're right up there in around where stroke, cardiovascular disease, all of these diseases that we think are really big problems. So what we do know from the literature is that physical inactivity is one of the leading causes of death worldwide. we sit too much, and we're physically inactive. And globally, a large proportion of adults are not physically active. And physical activity has been shown to have positive benefits on all of our systems in our body, our brain, our heart, etc. So if we look at that same frailty index on the left-hand side, we look at this score here, what we can see, again, the lower group would be the group that has no condition, but people who are physically active who have osteoarthritis are just slightly higher than individuals that have no condition, but those who are inactive are much higher, so they are much frailer at every age group. And in fact, actually, these are some Canadian data, and what it shows is that individuals that are 45-year-olds that are inactive has the same frailty levels as an individual who's 85 years old and no condition. So there are barriers to actually being physically active. And there are barriers for the average Canadian and the adult, and some of those are really access, we think, to different facilities and those types of things. But for individuals who have osteoarthritis or any form of arthritis, there is this fear that, and a belief that if we move, that we will create damage and we will increase our symptoms. And indeed, there are some people who they do get increased symptoms when they actually are physically active, because what we have to do is determine what are the best types of physical activities or activities that we can take part in. And what we know is that even osteoarthritis, we have 100 different forms of arthritis, but osteoarthritis is not one single disease with one single trigger that will develop that disease. There are a number of different triggers. So some people do have different types of pain, so not all pain is the same. Some pain is due to a stimulus, like you're loading the joint too much, and some is more neuropathic. So we have to be able to take some of these things into consideration. And one of the things that is a problem is much of what is in sort of in the media is based on how do we improve cardiovascular fitness, which is great, but some of those things are not actually good for joint health, as was chatted about in the last discussion. So we really have to be looking at where we are, what type of things trigger our arthritis, where we are along a severity spectrum with respect to symptoms as well as joint damage, and what's our health state at a particular point in time. And similarly, health providers, they don't prescribe physical activity. Less than 30% or lower in any studies actually prescribe physical activity as part of that clinical pathway. And there is also some concern that there is gaps in our knowledge with respect to what we actually know as far as how much, how long, and how intense we have to be working. So going back to that framework where we really study in our, how do I go back? What we really study in our lab is these changes in the structure of the joint have an impact on how we move, but how we move, if we change how we move, that actually can have a negative effect on the pathology, and we can get into this cyclical thing. And what I want to try and do is just show you some of the work that we're doing in our lab, where we actually measure how people move. We put little markers on the body so we can trace how the joints move. We have force plates in the ground so that we know what forces are acting on the joint. And we also can measure what the muscles are doing, so we know how hard they're working when they're doing these different types of activities. And we're really trying to link how people move to what types of osteoarthritic processes, either pain or changes in inflammation, and those types of things are taking place so that we understand what are the best ways to move. And this is likely not going to work because that's where we had a problem. But these are videos. This is a video from an individual who doesn't have arthritis. And you can see them walking along the walkway. That would be an individual who would have joint damage. So they actually walk quite well. This here would be an individual who has moderate osteoarthritis. And you don't see much difference there. They're walking a little bit slower than the other individual. But from the side view, if we can see their leg on the right-hand side is just kind of moving through. It is quite that the leg is just kind of moving through. So there's some slight changes that are taking place in their walking, what we would call walking quality. And this one here would be a severe individual, and this would be from the frontal plane. And we can see them walking along, and they have a kind of bow. They're walking slower. But from the side, we can see they're just picking up their leg and hiking down. It's just being pulled through. They're not bending their knee when they're walking. So some of the things we can actually see when we're just visually looking at them, but some of the things we can't, and that's where in the lab, so if we go to the next slide, in the lab, that's where we can measure some of these things. And what we find out is that the quality of the walking for individuals as they go along from being an asymptomatic individual who might just have some changes in their radiograph but no pain, to an individual who is has moderate osteoarthritis where they are quite functional, but they are not candidates for surgery. They can walk up and down stairs reciprocally, those types of things. Their changes in their quality, we can measure. This here dark solid line would be a normal individual where they're having nice loading and unloading of the joint, loading and unloading of the joint, whereas that individual who had the stiff leg, they don't have that unloading and loading of the joints. They would be the little dotted line down here. So what they're doing is they're loading the joint the entire time in the same place, so they're not getting nice motion that the cartilage actually wants to have happen. They're loading that joint. This measure here tells us how much they're loading each side of the joint. So we have the medial side and the lateral side of the joint, and we know that people are loading those sides of the joint differently. And then what we see at the very end over here, if these are the muscles, this would be the asymptomatic individual. They're not using hardly any muscle activation. They turn it off right away, whereas the individual here who has severe osteoarthritis is contracting their muscles the entire time. And these are just the quadriceps muscles, so the muscles on the front of their leg, but they contract the ones in the back of their leg, the front of their leg. They try to hold their leg completely stiff. So just imagine if you turn around and say, well, you know what? You should be walking 10,000 steps a day, right? I don't think so. That doesn't make any sense at all. So what we need to be looking as well is at the quality of the movement. So when we're looking at going back to this classification of function, we're saying what goes on between this impairment and the limitations and the changes in the movement. We have to address those before we start saying, okay, now go out and do all of these different types of activities. So the quality of the movement is extremely important. So if we if we look at ways to address sort of the participation in physical activity, we want to look at some definitions of physical activity. We have to look at what exercise is, and what we have to do is look at sedentary behaviors. And what we do to measure physical activity is we use these little pedometers or accelerometers that you can put on the individual to see how much they actually move. And when we talk about physical activity, all we're talking about is any activity that requires your muscles, your skeletal muscles, to work. So you're generating energy to actually move. And they can be any one of these items that are up here, like mowing the lawn, dancing, those types of things. And these things can be built into your everyday activities. You don't have to put on a tracksuit, swimsuit, whatever, to be physically active. You can just do different types of activities that would be part of your daily life. And walking is a key activity because that one is feasible and you can do it in all kinds of different places. Exercise, however, is a planned activities, and they are under the umbrella of physical activity, but they are specific. You're trying to target something, whether it's increasing flexibility, increasing strength, increasing your cardiovascular fitness. And they tend to be at a higher intensity. Physical activity, you can have light physical activity, you can have moderate physical activity, and it just depends on how much metabolic energy you're using for each one of those. Whereas exercises can be more vigorous, but some exercises like flexibility exercises would not be. But exercises are planned, and they usually will require someone helping you develop what that program might be. This one here is the kicker, and this is where we have a major problem, and it's our environment as well as societal sort of issues. We are very sedentary. So that means that we do a lot of things that don't require any metabolic cost associated with them because you're not using your muscles. And these types of activities are extremely bad for your overall health. So sitting in front of the TV for 3 or 4 hours is not good for all kinds of biomarkers related to your glucose levels, those types of things. But I just want to make sure that, can you just go back? Because the sleep, so my animation is gone. Okay, so go back, please. Yeah. So this should disappear. Sleep is not a sedentary activity. Sleep is a requirement, and good quality sleep is extremely important for health. But we spend lots of time in sedentary behaviors. So low physical activity, sedentary behaviors have a negative impact on all of our different systems. There's research to support that cognitive function, your memory, depression, your cardiovascular system, your skeletal system, your muscle system, all of these systems are negatively impacted by lack of physical activity or high levels of sedentary behavior. So if we look at some of the work that we've been doing in our lab with looking at individuals who have osteoarthritis versus those that don't, and this is consistent with the other literature, individuals are less physically active who have osteoarthritis than individuals that are age matched who are not. But I would have to, this is from our Nova Scotian population, and almost 7,000 steps a day is actually not too bad. And this is for a moderate OA group compared to some of the U.S. numbers for sure. And they spend more of their time in more light physical activity than moderate to vigorous physical activity. And that, again, may not be a bad thing based on it is less vigorous or less stress on the joint. But what we found also is people who had those poor walking patterns had the lower levels of physical activity. But what we also found is we did a follow-up to find out how many people actually progressed either structurally or went on to have total knee arthroplasties at follow-up. And what we found was the frequency of activity, keeping in mind that the frequency of activity for these individuals are lower, but that frequency of activity didn't have an impact as far as the higher frequency of activity didn't have an impact on individuals who actually advanced to total joint arthroplasty. It was more the quality of walking that was the more predictive value. If we look at OA versus no OA, as far as strength is concerned, what we found was that individuals were, as far as men were concerned, the asymptomatic individuals and the moderate OA individuals were similar with respect to their strength. The severe had lower limb strength values, but for women, all three groups were different, with the asymptomatic group having the higher strength values. So the issue here is really that we do think that there are some differences in how women and men sort of respond to the disease, and we know that there are different prevalence levels, and we also know that oftentimes men will have one or a single joint problem and more women will have multiple joint problems, which indicates that there is some systemic thing going on as well with respect to the arthritis. We also know that really high strength values for individuals with osteoarthritis, if they have an instability in their joint, or if they have sort of a misalignment, so a more bow leg or knock knee type of alignment, that they are more, if they have higher strength, they are more prone to progression. And the issue is what we have to oftentimes trade off is people always talk about you really have to strengthen your muscles, those types of things, but you don't need Arnold Schwarzenegger quadriceps or, whatever, a six-pack abs. You just need enough strength to be able to do the types of things that you need to do. And some individuals, like most of our moderate OA men, you would not put them on a strength training program. You would look at other types of programs. We know from the literature that some high-intensity types of exercise do exacerbate symptoms, and we have to better understand that. And neuromuscular exercises, like the one that was talked about previously with respect to the GLAD program, those types of exercises are more likely to change your quality of movement, so your quality of walking. So those types of exercises are good types of exercises to do. So as far as sedentary behaviors are concerned, what we found was they were similar between the asymptomatic and the OA group, but you're spending almost 2/3 of your time in a sedentary type of behavior. And we know from the literature that really has an impact on your physical function, your ability to function, because you will have atrophy, you'll have stiffness, you'll have all kinds of things happening. If you have an increase in pain, then that becomes cyclic, and you don't want to move. And then all of the negative health benefits that we're beginning to see when individuals are sedentary. And only just decreasing your sedentary time, breaking it up, and inserting some light activity will actually help improve those health outcomes. And it's also been shown that it helps improve pain, because sometimes you're sitting there for long periods of time and you go to get up and you're stiff, you're sore, all of those types of things. The other study that we actually did was looking at individuals guidelines talk about doing 30 minutes of continuous exercise. So what we wanted to do is say, okay, let's look at what 30 minutes of walking does have, what kind of effects that has on things like pain or biomarkers associated with, like markers in the blood that are associated with inflammation or cartilage damage. And what we found was that half of the individuals after 30 minutes of continuous walking did have an increase in pain. The other half didn't. And again, that goes back to saying that there are some differences in pain, because those individuals who had an increase in pain also had an increase in sensitivity when we measured it objectively, not when we just asked them what their pain level was, but when we actually did a test, which was a pressure sensing test, which would indicate that they may have a neuropathic pain problem. So we have to turn around and take that into consideration when we're saying, yeah, go walk for 30 minutes. Maybe they only can walk for 10 minutes, three times a day. And we need to begin to really understand that. What happened at the end of the 30 minutes in all the groups, so not so in an OA group that had high or poor quality walking patterns, an OA group that had good quality walking patterns, and an asymptomatic group, all groups, their muscle activity decreased as the longer they walked. So that would be a positive thing. Their muscles aren't working as hard, so they're not likely to fatigue as quickly. But what we found was that the individuals who had the poor walking patterns did have some increases in some of their markers from their blood that were related to cartilage damage. So again, that sort of says we need to be looking at what the dose is and how long those individuals should do that. So overall, if we go back to our clinical pathway, what I'm suggesting is that we have our diagnosis of osteoarthritis, which has our cartilage damage as well as our pain and symptoms. And we go to a path that actually includes some of these exercises that would be specific to that particular individual's needs, such as these neuromuscular training programs, or if someone did need some strength programs, with the goal of trying to improve their mobility, the quality of their walking. And if we need to do some type of pain management through medications or other types of approaches, and my colleague, Dr. McDougall, will be talking about that next, that's all part of the package. And that what we want to do is say we want to be moving so we improve that so that the individual can take part in these physical activities and be able to participate in the different types of activities that we would like, and move along a healthy aging path. If something happens that their joint does end up, they have a worsening of pain or some other functional issue, then they go down the joint arthroplasty path. But we want to be at a level that if that happens, that after they are finished getting their joint arthroplasty, they can come back down onto that healthy aging trajectory, because that doesn't always happen. And we do see that post total knee arthroplasty, sometimes we don't have great improvements in our quality of walking. So the issue is that this here approach does require some change, because you can't just tell someone to go do something. You can't say, okay, now, go be more physically active. They have to have some guidance, in particular if you have to do specific types of exercises, if you have other comorbidities like a heart problem or that type of thing. You do need to be working with a health provider to be able to help you navigate that system. And also we have to be able to figure out how these things can be delivered more remotely. And we know in our province, we do have a large rural community, and they might not have a swimming pool where they could go do a water exercise program. So we need to be figuring out that whole model of how we can integrate that and not just have not just say, well, we'll manage the pain, and you have to figure out how to manage some of those other issues. So if we just look at the take-home message from this, what I want to highlight is movement is necessary for your overall general brain and body health. And there's lots of literature to support that. There's literature to support that it improves your joint health as well. The quality of the movement, however, is extremely important. And if it means, not only the exercises, but if you need to have a brace or a cane or something else to help you so that your quality of movement is improved, so be it. The key thing, I think, is trying to remain physically active and really reduce sedentary times. And there's lots of work in this area where we're really trying to figure out what the best way is to do that, but just including things like if you're watching television, every time a commercial comes on, and Lord knows there's lots of them, you get up and you walk around your house, you take a walk up the stairs, because breaking up that time is even beneficial. Because the literature supports that if you break up an hour of sedentary time with 5 minutes of activity, then you can maintain your health benefits. So the intensity, duration, frequency of of what types of activities you take part in, as far as physical activities are concerned, really as far as light to low-level types of activities are highly beneficial. And reducing your sedentary times are beneficial. But our future research really needs to focus on delineating what those intervention doses actually are so that we are a little bit more clear on that. And I would say that for right now, relying on sources that are based on evidence is very important, because you can go on the World Wide Web and you can get all kinds of ideas as to what types of exercises you would do for osteoarthritis or other types of conditions. But the issue is that many of these approaches have not been evidence-based with respect to individuals who have osteoarthritis or other forms of arthritis. And you have to be very careful, because when people say, okay, go do some strengthening exercises, and they're telling people to work at 80 or 100% of their maximum capability for X amount of time, that may not work or be appropriate for that individual at all. So there are some resources that are online at the Arthritis Society, and these resources are vetted. Okay, the Arthritis Society is committed to trying to improve the quality of life of individuals who have arthritis, and these online resources are resources that can be trusted because they are vetted within the Arthritis Society. So I would suggest looking at those as opposed to some of the other ones that may be available to us. And I'd just like to acknowledge first the participants in our many studies. We have a great group of individuals, some who we've done follow-ups on, and they provide us with lots of feedback, which is extremely important. We even have some of them who help us with designing our research projects, and they have input on that. I have two of my colleagues, Derek Rutherford in the top corner and Janie Wilson in the bottom left corner, as well as I work with two orthopedic surgeons, one Michael Dunbar and Dr. Bill Stanish. And I'd just like to thank you for listening, and I would be happy to entertain any questions.
All right, so we'll now open the floor to some Q&A. So if you have any questions online, make sure you type them in the chat. We have a moderator that will pick up those questions. Of course, in the room here, please raise your hand, and if you're at the Sydney site, let your volunteer know so that they can put the question in for you, and we'll be golden. So take it away.
Okay, first question over here.
Mine is not so much a question as it is my health. I guess I've had osteoarthritis for about 10 years, and I was one of those ones that was looking for all the magic cures. I just threw out a bag. I'm sure it was worth $500. Of tubes of everything you can imagine. I've tried it, including horse ointment. Oh, I had a great conversation with an old guy. It's always about this horse medicine, this ointment. It didn't do anything for me. But I seen Dr. Dunbar for 5 years. Him and I are great friends. I love him. I would praise him up to the highest. And I went in September of 2016, and I literally sat with one of his coworkers for 3 hours, and I'm not exaggerating, and I talked my way out of, no, I don't need surgery. Look, I can walk, I can move. In November, I walked in there, and I was in tears. I was in so much pain. So he got me in February, but then my mother ended up dying, so I didn't have my surgery done until September. And I got along really good. And then 8 months later, I was supposed to get the other deed done, and the mom's house sold, so I had to go back to Cape Breton to look after that. So 10 months apart, I had the second knee done. And I can honestly say I would recommend it to anybody, although I did talk to somebody here today who said her brother had his knees done 2 or 3 times. And I've heard people that have had really bad luck too. But I can honestly say that having my knees done has changed my life so much that I can't even express the difference in the feelings. Like, the pain is gone.
Good. Thank you.
And it's the only way to get rid of the pain.
Mm-hmm.
You can say all you want, oh, this works, that works. Nothing works permanently unless you get those knees done. And my biggest fear was fear. I was petrified to be put to sleep. I had a fear like you wouldn't believe. And the pain got so bad, I just said, that's it. I got to suck it up and I got to get it done. I had no choice. And
I think there are some that's true. There's some that you get to a particular point, and that's what I'm saying. If you fall off at some point, at least if you can be healthy afterwards, you can come on. But we do know that about 20% of people are not satisfied. But I think the key that we have to think about here is intervening earlier. Okay, intervening earlier so that we can actually prevent it. Because the issue is if there are 250 million people worldwide, and whatever it is in Canada, that's a lot of orthopedic surgeons. And Dr. Dunbar has written a paper on the whole thing with, we don't have the resources to do this. So what I'm talking about is backing this whole thing up. So when we're looking at when someone comes in, that we actually start to do something at that particular point in time. Many people don't have access to physiotherapy, for example, or many people don't have access to being able to afford a brace or other types of interventions that, if they're done earlier, might be able to slow that process. And that's what some of the work is that we're doing. Once you get to a certain point, That's great. Yeah. Good. Thank you.
All right, so we have a question at the back of the room.
Hi. You mentioned osteoarthritis as a disease over here to your left.
Oh, okay.
In my case and my siblings' case, genetically, we all had to have our knees replaced in the 50s. And one sister, a nurse for 39 years, my older, raising 2 children as well as she could be active, she was, and I was very active. And but is there a genetic trigger? Is that one of the triggers, or is that proven? And if so, can't see it in our genes, family is gone, haven't family we could trace back to?
Yeah, so there is a genetic component. That light's really bright. So yes, so when I talked about like the personal factors, there are factors that are genetic factors as well. So some people would be at higher risk, okay, which is what happens. It doesn't mean that you would have the same endpoint. You're actually at a higher risk, right?
Great. We have another question that's come in from our Sydney viewing site, and they say, please explain what neuromuscular activity is.
Okay, so neuromuscular activity is just your brain and your spinal cord control your muscles. So neuromuscular activity is just your brain or your spinal cord telling your muscles to turn on and turn off. And that's really important because we do know that when we perceive pain does have an effect on the brain, and that can change how your muscles work. Also, we know that if the joint moves in a certain way and you stretch one, a ligament or a structure on one side, that can trigger the muscle to work. So that would be the neuromuscular activation patterns. And those are changed, as I indicated, as you go across severity levels where the muscles work harder and they work for more prolonged periods of time. And sometime that might be related to the pain, because the pain may be the trigger. Like if your joint is unstable because you've decreased the cartilage, so you have more passive laxity, like you can move that joint. Your muscles say, ooh, that doesn't feel good when I move in that way. So your muscles turn on to try to stop that from happening because it's painful, and that actually goes on and can precipitate other issues. So it affects your quality of your walking.
So next we have a question from one of our online viewers, and they'd like to know, how can we slow down the effects of osteoarthritis?
Okay. So this is what we're really trying to understand, and I think that's a loaded question, and there are lots of factors that come into play, and it really comes down to the fact that osteoarthritis isn't a single. Like we're finding that there are different, we call groupings of osteoarthritis. So there's some factors that have been shown to help. One of them is reducing weight. Physical activity has been shown to have positive effects on pain and symptoms. But we know that there are some people who we really have to think about what of your joint health, and I think maintaining an active lifestyle, your diet, all of these things actually can come in to play. And I think important is managing the pain. And if you can manage that with different types of there are different types of approaches to do that, but it is key to help us move in an appropriate manner. Some of it likely is genetic, because we have some individuals who've come into our lab, and we know that they we followed them for 13 years. And even individuals who were at the same level of pain and joint damage when they first came in, these people 13 years later, same age, the whole shooting match, they have not progressed as far as their symptoms are concerned. And really trying to understand why. When we do look at their walking patterns were good walking patterns or quality walking patterns back then, and they haven't changed a whole lot, whereas other individuals do change. So I think there's a number of factors that actually come into play, and it really is looking at sort of a personalized approach, because it is complex. It's not just one factor, but like weight loss. And again, you just can't tell someone to go lose weight. You have to help individuals do that. You can't tell them just to go be physically active. We have to provide resources for individuals to do that. So all of those, I think all of those combinations of things, because there are some people who don't go down that path.
All right, so we have time for one more question, and it's from one of our online viewers elsewhere, and they're wondering, should a person with severe facet arthritis 4 through 5 do lower back exercises?
So again, it would depend on what types of exercises you would do. You would not do strengthening exercises like high weights, but movement, is good. But I think that you really have to have your therapist assess what limitations you have. And determine whether what type of exercise might be good for you. Okay.
Thank you.
Great. Is that okay?
Thank you so much, Cheryl.
Okay.
That was a wonderful presentation, and thank you for answering questions. Again, we'll give you an email at the end of the event, so if you have any follow-up questions, since we do have limited time to answer them, we'll do our best to get a response to you, so we'll give you that at the end as well. So thank you again so much for that, and we're going to take a short break now before we go on to the next presentation. So Jason McDougall. So we're going to take a 5-minute break. We'll come back around 2:40 with Jason. Awesome. Thank you, guys. There should be a countdown timer as well, and we'll let you know when we're about to begin.